Good morning and welcome to the second day of our spring virtual conference of Academy of Oral Surgery. Today we have a host of world-class speakers with us. I have right now with me Dr. Samuel Lau, and he's doesn't need any introduction, of course, but I'll do read over his credential momentarily. We are streaming this over our Global Summit Facebook pages. There's some CE units that I definitely recommend if you guys are interested can get after this presentation. Wanted to encourage everyone to become a member of the Academy of Oral Surgery. We are offering a first-year free membership, this is obviously we're offering this free for this first year for the 2021 year, and also wanted to very excited that we are having our fellowship and mastership. We're going to announce those very, very soon. Also, the International Extraction Academy hands-on workshops. We used to have a dozen of this. We started these workshops years ago, but because of COVID, we kind of had to shut down. But we're having them back on for now in California, in Los Angeles, mostly. So whoever wants to sign up, we have a special today, 50% off your enrollment by using the code AOS 2021. So we'll have this up again for you on the side. You guys can use. And with that said, I want to go ahead and Dr. Sam Lau is a professor of Emeritus of the University of Florida College of Dentistry. He's also an associate faculty member of the Pankey Institute with over 30 years of private practice, experience in periodontics, lasers, and implant placement. Dr. Lau is a diplomat of American Board of Periodontology and past president of the American Academy of Periodontology. Now, and this is, again, it's not a news. Dr. Lau is basically the icon for laser dentistry, and obviously more recently that with the advances in the laser industry, and what we're having, we see every day with Peri-Implantitis, and this is very exciting to know that there's an option now for treatment of these cases, that they're growing every day. So, Dr. Lau, it's an honor to have you with us.
Well, thank you very much, Dr. Javid. It's good to be part of the organization, and it's a very critical part this time in our dental profession to have such organizations as the Academy of Oral Surgery, and especially from a global aspect of it. And so I do want to share with our audience an area, and you mentioned, and you were right on target. We initially, the addition of the dental implant to either the completed edentulous or partially edentulous patient was considered a panacea. And during that time, multiple decades ago, it was the case. And if we go back, especially if I look at North America, the advent of a bridge or a partial is very well down the list of treatment plan options for patients. Implants have gotten much better in not only their surface areas, the architecture of them, ease of use, but more importantly, on the treatment planning aspect of it, including CAD/CAM technology, surgical guides, and now even we're starting to touch on robotics. And with the significant number of implants that are placed, and with that, in the United States, we think that approximately 3 million implants are placed a year in the United States. With that number of implants placed, and then you go back 2 or 3 decades, and the increasing number of implants placed, unfortunately, there is another sort of aspect of that, and that we now appreciate that not all implants are going to be there forever. And we get into this scenario called peri-implant disease, in which there really are 2 categories. One is the implant mucositis, which is basically the gingivitis of around implants with no bone loss. And then we get into, unfortunately, the implantitis, which is actually osseous resorption due to several reasons. It can be microbial, it could be the way they were placed. There is the possibility of titanium sensitivity. We'll talk something about that. But whatever it is, we're approaching, in some studies, understanding that approximately 1 out of every implants are lost over the lifetime of the patient having had an endoosseous root form implant.
Absolutely.
My objective with you today in our brief time together is to suggest to you that not all implants that have implantitis should be lost, and that if we can intercept early with whatever modality you desire, that we can actually stabilize many of these implants. Every speaker, oh, by the way, if you are observing my title slide, I always believe in sharing. And this is my email address. Below is my website. So if you would want a copy of this presentation, or want me to answer any questions, or even send me a radiograph of an implant that you're struggling with, please do. It's slow@dental.ufl.edu. And yes, I am at the University of Florida College of Dentistry. I have practiced there for over 3 decades. And now I primarily am an attending with perio and ortho profs, and I only do laser surgery. However, all speakers should give you their disclosures at the very beginning. I helped create Florida Probe Incorporated, which is VoiceWorks. It is the way of doing periodontal examinations through a headset. Perio Sciences is the only antioxidant wound healing gel around, for especially post-surgery. BioLace, I'm the Chief Dental Officer for BioLace, so that's a significant disclosure for you. Philips Sonicare EMS, the standpoint of the airflow, and Probiora, which is the oral probiotics that are out there now. What we want for you to consider taking home is to explore primarily, how do these implants become inflamed? Once we have that inflammation, how do we deal with it, both traditional, and the primary objective of our being together for this is where lasers fit. And then also look at where lasers fit not only in the therapy, but how lasers fit not only with efficacy, but are there any adverse events? If one looks at the history of dental implants, 2000 BC, using shells and ivory to replace missing teeth, and it was approximately 1951 through 65 that a gentleman by the name of Dr. Brandemark, a surgeon, medical surgeon, began to look at the utilization of titanium implants for maxillofacial prosthesis. And that began the whole concept of what we call osseointegration. And from there, implants, dental implants were wide, they were narrow, they were shallow, they were deep, every surface imaginable. Machine surfaces, anodized surfaces, SLA surfaces, calcium phosphate surfaces, titanium plasma spray surfaces. And now as we move forward, in the late 90s, it's hard to believe, but in the late 90s, early 2000, we began to look at the whole concept of all-on-4, all-on-6, zygomatic implant placement. And now, as we move a little more forward, we're working more on scenarios as cell structures, and also now looking at robotics. So in the United States, and actually, if you look at Europe, Europe places a heck of a lot more implants than we do, whether it be Italy, etc. But we are about a 3 million implant business a year. It's a $6.5 billion industry. We're not really sure about the failure rate. However, you can imagine there is stiff competition among implant companies, and some have come and some have gone, and some have been able to stay. It's not to go completely back to the basics of what an implant is, but I do believe that sometimes we forget the difference between a natural tooth and an implant surface. They share characteristics, and there are major differences. They both have a sulcus, they both have junctional epithelium. That's probably where it ends. The natural tooth has supracrustal fibers, literally Sharpie's fibers, really attached into the cementum. Then we have the periodontal ligament, and then we have bone. Whereas the implant, it may have connective tissue there, but it is an adherence and not an attachment. And if you probe with a fair amount of pressure, your probe will end up on the osseous structure. So in the bottom line, where teeth are in bone, they're really not in bone, are they? They're really surrounded almost like a trampoline of connective tissue, PDL, where the implant has a surface that is literally osteointegration, we hope. And our quest in doing implant procedures is what? To keep the epithelium out. Basically to keep the epithelium out to allow that osteointegration to occur. What we're finding is that where we were so much blaming the loss of implants, implantitis, whatever, on microbial aspects, or the way they were placed or overheating the bone, we're now starting to be more realistic and understand that many of the complications with implants are not microbial, they're restorative. And when we look at this, and if you're in an implant practice, maybe not your implants, but what you're seeing is fractured, loosened screws. I see it every day. Fixture loss. Yes, poor oral hygiene. Soft tissue reactions. Placing implants in minimal or no attached gingiva, especially with all-on-4, all-on-6. Broken attachment. Fractured components. We take implants out many times because they're fractured. The cement issue, if you catch it early enough, can be reversed by literally reflecting a flap and removing the cement. But if you don't catch it to where now you've got an ongoing inflammatory process and you've got halfway down the root with threads not integrated, then your prognosis begins to, for every thread you go apically, your prognosis gets poorer and poorer and poorer. But you and I both know that we're getting less and less and less cemented implants and more screw retained implants. But let's not rest in our laurels there, because as you can appreciate, screw retained implants also have their issues. We forget that the contact of teeth together is 24 hours a day, and we're looking at an environment that is probably unlike anywhere in the body as far as the pressure and the saliva, the frequency of the pressure. And we're trying to put person-made things in there and hoping it's all okay. If one looks at the implant surface over here on the left, and you literally are looking at mesial versus distal, you'll notice that on the left of this, there basically is, to a certain degree, osseointegration. But over on the right surface, there's a substantial amount of osseous resorption. Now let's look at the slide over on the right. And here, you don't see just like angular bone loss that we see in perio. I am a periodontist. No, what you see is massive amounts of osseous resorption that are not only apical, but also in width. So we're asking ourselves, how can this happen? And if we're depending on our patients to tell us it's going to happen, it's no better than them coming in and telling us they have periodontitis. This is a very recent study, 2021. Results of this study demonstrated that peri-implant diseases are not perceived by most patients. When patients have severe symptoms and try to pursue dental treatment, it's probably too late to effectively treat peri-implant disease. There are some of us in the profession that believe when we see implant disease, we should watch and wait. And then when it gets halfway down the route, we should take the implant out. I'm going to suggest to you, I don't want to do that. I don't want to watch and wait. We're going to reflective flap. We're going to deal with it the first time we see any osseous resorption. And we're going to have a very good chance, unless it was placed inappropriately, we're going to have a very good chance to reverse it. So the European Federation of Perio and the American Academy of Perio got together beginning in 2016, 2017, and developed a new classification of periodontal disease. However, this was the first time they also added implant diseases. And this is, by the way, in the www.perio.org, if you would like to take a look at that classification system. And those four are health, mucositis, implantitis, but they added a fourth, deficiencies of the alveolar ridge caused by natural healing, extraction trauma, infections, or a variety of other factors. I'm beginning to believe that there are more of this than there is literally what we call peri-implantitis. To reiterate, we have mucositis and we have implantitis. I'm primarily going to focus on the implantitis, but I will suggest where lasers might be used with mucositis. Now, we don't have it much easier in trying to not necessarily find implant disease, but determine the level of implant disease and thus the level of prognosis. It's a struggle to probe implants. The convexity, especially in the posterior, is substantial. And therefore, we're all over the board, validity and reliability, in looking at what the depths are. My takeaway now, and what I recommend and teach, is to use the probe not so much for the numbers, but to use it to determine bleeding and especially suppuration. However, probably the most premier diagnostic is the radiographs. And you and I both know there's a huge issue with radiographs, and that is much of implant disease is on the buccal and the lingual palatal. It's not like teeth. And when you do see that, that's generally not microbial. That's the way it was placed, either buccal verted, lingual verted, generally buccal verted, or the fact that, from that standpoint, there is fractures, there is screw issues. And so when we take a look at that, I do probing to determine resorption, not inapproximately, like you see on natural teeth in the caul area. I'm trying to find what is the topography before I reflect this flap on the straight buccal or lingual. And we continue in some circles to ignore occlusion, which in my mind is a significant mistake, because bone is not concrete. It's a very viable type of tissue, and then attached gingiva. So it's very difficult, if not impossible, to probe along the long axis of an implant unless you take the fixture off. And so here's what we're dealing with. How do you probe this? You don't. How do you debride this? You can't. How does the patient do any type of oral hygiene? They don't. So for our patients, for the most part, it's a real challenge with oral hygiene. And we come up with all kinds of devices, most, which even if they were effective, patients aren't going to do. Yeah, this is a great slide showing you, but I'm doing this, not the patient. It's time to start looking at more user-friendly kinds of things. They may not be perfect, but at least the patient's going to use them. And even if they use the advanced and just use it from the buccal and disrupting the biofilm, I will be fine. So we need to start reintroducing and being creative and quit using this floss thing around implants. In fact, some studies show that it actually tears up the floss, which becomes a foreign body. So one needs, in the implant game, to truly develop your protocol that you want to send patients home with. And in my mind, it's interdental brushes, soft picks, things of this nature. This is how you debride implants. I would also suggest to get rid of manual toothbrushes. Well, basically, I think you got to get rid of manual toothbrushes, period, and go to power. And then begin to look at these new technology devices that are like air floss or these new oral irrigators. Oral-B, P&G just came out with one. Looking at these new lithium battery-based types of devices. And also look at what you want to put in those devices. When we look at non-surgical studies, what we find is that we do not know how to non-surgically manage implants. We tried this. It doesn't work. And even if you use metal of any sort, especially ultrasonic, what you'll see over on the left will end up with what you see on the right. So from a non-surgical standpoint, what are we going to do? I told you that I have a relationship with EMS. And the reason I have that relationship is I am convinced that air medicinal devices, not prophy jets with sodium bicarb, but the new air medicinal devices, I say new in the US, decade in Europe, with these powders that are like talcum powders, like glycine, erythritol, plant-based. That is what I've been using for the last 5 years. With hygienists managing implants, and even during the surgical procedure for implantitis and periodontitis, I'm using these devices. Now, probably the most ideal is what you see in the lower right. And that is an airflow, that's probably the prophylaxis master from EMS, but there's other companies that make these kinds of devices, Acteon, etc. When you look at how effective these devices can be, however, you've seen this. This is with the overcase taken off, implant supported removable denture. And if I ask you how long it took between what you just saw and now, with anything you have, what if I told you I was able to do this in basically 30 seconds? So from a non-surgical standpoint, I can only think of one area. I would love to give you multiple types of options. But for me, it is glycine or erythritol airflow devices where they have water, they have air, and they have the medicinal that's able to do this. And that is where we're all going. But let's you and I shift now into peri-implantitis. In peri-implantitis, again, the osseous resorption is substantial. Again, if you'll look at the first bullet, this is 2014 in the United States. 18.7% of implants are considered failures. The number one risk factor is a history of periodontal disease. Again, a substantial number of implants placed. And this is from Dr. Stu Fromm, if you just took 10% a year, that would be 273,000 implants are lost. So what are we going to do? We know that a history of implant disease, oral hygiene, not regular maintenance. We know that nicotine ingestion, we know all of these things create. And we also know that sometimes it's us, the way we place them. You know, what we're doing, are we placing them buccally? I mean, you know, all these kinds of things. No attached gingiva. One of my pet peeves. And studies are beginning to show more and more and more of loss of implants relative to attached gingiva. And so there are these significant risk factors for implantitis, but they're not just microbial. And they're not linear. They're episodic. Perio disease, with the exception of severe with abscesses, is linear. No, this, my friends, is major episodic. And it depends upon the surface that you're looking at. Is it an anodized surface with tyanite? Is it SLA surface? Is it a machine surface? Recently, and it began in 2015, we began to think about foreign bodies associated with implant disease. In other words, titanium oxide, particulates in these inflammatory cascades that we're seeing. And this was in electronic print and now in print by Tom Wilson just recently about metallosis, which we do see, by the way, in orthopedics. And what he's suggesting is, don't think this is all about biofilm. This is both metal and biofilm. Inflammation from oral biofilm, but also includes an inflammatory response to titanium particles and ions. And you know what we see with that? We see giant cells with this. And we think this is the result of corrosion, the result of fretting. There's a term now, tribal corrosion, And therefore, a series of studies demonstrating dissolved titanium detected in submucosal plaque, which actually is becoming the stimulus. And it may be a reason why there is so much going on relative to the ceramic implants. So let's sort of finish up and begin to discuss implantitis. Mucositis, I still believe it's air medicinal delivery. If you don't have that, then I would suggest that you try to find ultrasonics that have polymer type tips, but I still don't think they're that effective. But what do we do with implantitis? The primary way we deal with implantitis, by the way, is we reflect a flap. But now the flap is reflected and we remove the granulation tissue. What do we do with the implant surface? And what we do with the implant surface depends upon who you read. We've used citric, it's called, where we're going to get to here right now, and to be very candid with you and transparent with you, is what do we do now with the implant surface to make it to where we can get new osteointegration? We've looked at citric acid, we've looked at tetracycline, we've looked at lasers, you name it. EDTA, we've looked at everything. And yet there are no real compelling studies to determine what we should be doing. But it really comes down to decontamination. And it comes down to the threads. Are they small threads? Are they big threads? What is the surface? And this is from a couple of studies. Implant contours and surface are a limitation to removing the biofilm, because really there are multiple perforations if you think about it. Surface treatments include erbium, photodynamic, air abrasion, implantoplasty. But many of us reflect a flap, do something that's in vogue for that moment about working on the threads, put some osseous grafting, biologics, maybe a membrane, and suture it back up and hope for the best. We've already gone through the implantoplasty era. I think we have. But that's what we were doing, weren't we? We were trying to reduce the threads to where we make it more like a machine surface, thinking that if there weren't the threads, then there would not be the deposition of the biofilm. But you do know that it's machine surface, so your chances of osteointegration are minimal. And think of what we were doing. We were literally, by the nature of taking the threads off, we were throwing the titanium particulates all into the tissue. And if we are right, and we are, about the giant cell reaction to these as a foreign body reaction, then literally what you're doing is enhancing the inflammatory process instead of reversing the inflammatory process. But we've come up with everything. Very few of us touch an implant brush now. First of all, we realized that the implant brush actually didn't get into the pitch of the threads, which is an issue. Which now brings me around to our topic of focus, and that is about laser. And where do lasers fit in all of this? Some of you are maybe very aware of lasers. If you don't mind, I want to go through maybe just a couple of minutes about laser technology. First of all, lasers are nothing more than light. That's all they are. The difference is they're organized light. They're collimated light, instead of like what you see with a light bulb. Dental laser wavelengths are over the entire electromagnetic spectrum. A laser is not a laser. Our red pointer, that is in the visible spectrum. You can probably see my little arrow. Then we get into the near infrared. which now we're into the invisible. If we did not have an aiming beam in the red spectrum on a dental laser, we would know where it was going. And we move from diodes to the Nd:YAGs over to the erbiums, and we end with our CO2. So a laser is not a laser. The good part about laser energy, however, in the electromagnetic spectrum, is that it's non-ionizing. It will not affect the nucleus whatsoever, versus our radiographs, which are ionizing. In this electromagnetic spectrum, here are the argons, and notice where the diodes come in, and they're in that 810 to 980 range. The erbiums come in, both erbium chromium YSGG and the erbium YAGs. And then again, we finish up with our CO2s. So here's what I'm going to suggest to you. Tell me what you want to do, and I'll tell you what wavelength to use, and you generally cannot defy it. So with our diode lasers, they absolutely can have an effect on bacteria. But is that basically what we're trying to do here? And are we also trying to degranulate the wound? Now, the beautiful thing about the diode laser is they're inexpensive. The beautiful thing is their absorption properties are significant. And if you know photodynamic therapy, quite popular in Europe, where you put a dye in the bottom of the sulcus, the laser energy looks for the dye. You only have to put the diode tip within 1 millimeter of the inside of the sulcus, hoping that the dye will be incorporated into the periodontal pathogens. And so diode lasers are inexpensive, fairly easy to use, and that's why they're the most popular laser adopted in the world. The problem that occurs with diodes, however, is that they are more than often thermal devices. In other words, when you see them cut through tissue, ablation is generally a thermal activity. Now, we don't like over thermal activity on soft tissue, but naturally we don't want any thermal activity on bone or titanium. Because if you increase the temperature of the titanium, you will get a thermal reaction of the titanium surface to the osseointegration. And if you begin to have significant thermal, then you'll necrose the osseous and you'll slough the implant. And there is a running debate. Can you use a diode on a titanium surface? It just depends upon who you read. To avoid thermal or physical damage to implant surfaces, the radiation treatment has to be carefully selected. In other words, what is the wavelength you're using? What's your wattage? Is it going to be initiated or uninitiated? How long are you going to spend in it? Are you just going to touch the soft tissue inside the sulcus, or else you're going to touch the implant itself? What are you really trying to do with the laser if it's a diode? This study supports that CO2 laser treatment appears more useful than the Nd:YAG laser, and that the CO2 laser does not damage titanium surfaces. Conclusion: regardless of power setting or distance, use of Nd:YAG on the osseotight surface will produce surface alterations. So now you've got some areas here. What am I trying to do with it? If I do use it, is it going to heat the implant? If it doesn't heat the implant, is it going to actually affect the surface of the implant to where I cannot get osseointegration? So one has to be careful with both diodes and Nd:YAGs, because if one is not careful, and these are SEMs using appropriate settings with Nd:YAGs and diodes, you can melt your implant, you can crack your implant because of heat. So when we look at these studies, the thermodynamic effects of laser irradiation, during laser irradiation dental implants, a surface temperature beyond the critical threshold of 10 degrees centigrade can be reached only after 18 seconds. We are not suggesting not to use diodes and Nd:YAGs. We're suggesting if you do, it's incredibly technique sensitive. And knowing your settings and knowing your wavelengths is critical. So I moved into the erbium business. And the reason is that erbiums used appropriately, their action is not thermal, their action is photoacoustics. And now we begin to see those studies. However, when the erbium was used with a water spray, a decrease in temperature was observed in all implants. The acid etched and sandblasted surfaces were those most affected by any thermal changes. So we're able to clean these implant surfaces very, very effectively if we're watching what our settings are and we're using water. Notice the control part versus the laser clean part. And this is with photoacoustics. This is where the laser energy is seeing the water, causing microimplosions in the water. And those microimplosions is what is decontaminating, detoxifying. By the way, also removing veneers in 30 seconds off of teeth. If you desire to have a system for removing veneers and zirconium crowns easily, it is an erbium laser because of these bubbles and pressure waves that occur. When one looks at graphs and you look at this red and this blue, at the very bottom where you see almost no temperature change, I can suggest to you it is where water was used. If you do not use water, you will see a substantial increase in temperature relative to these implants. So we've done studies. We've taken the erbium chromium West UG. This is a water-based laser. We've taken those erbiums. And now we know that 95% of biofilm on all types of tested titanium surfaces will remove it without causing measurable physical damage to the implant surface. And we've used it on all implant surfaces, whether it be anodized, whether it be calcium phosphate. Naturally, with machined, you know it's going to be removed and removed easily. But even in the very popular SLA, bacterial ablation occurs. And it occurs very quickly within 0.5 watts, including also calcium phosphate. But remember, I suggested to you, it's not just about removing the bacteria. Let's make sure we're not hurting the surface. And if you look at erbiums, it has no effect on the surfaces whatsoever, with the exception of one has to be careful with anodized surface when you start going above 1.5 watts with an erbium or CO2 laser. The SLA surfaces are fine, but that anodized surface with sort of that laminate, you can see with SEM moving from left to right what could occur. We now know that these erbium lasers will also remove the resin cements and remove the resin cements quite easily, and also get into the pitch. You see, it's not important that we just degranulate on the outside or even on the outside of the threads. We've got to get on the inside of those threads if we're going to do any type of decontamination. And that's what these erbiums do. Great study by Yamamoto, International Journal 2013, and a continuation of studies with Mark and Ron Nevins. You'll notice that on a canine study with micro explosions, that over on the left, you see that the bone is not re-osseointegrating in the threads, but where we use the laser, it is osseointegrating. And what does that mean? It means that it's not just removing the bacteria, it's literally removing the titanium particulates that may be associated with the type of corrosion. And here's a perfect example of what we're trying to get to. Over here on the right is where we have the tyenite. Over here on the left is where it's been removed. And now we have the studies clinically. a study by Rana Al-Falaki, periodontist in the United Kingdom. If you and I go from left to right, it's not perfect, but this is without osseous augmentation or biologics. Notice on the bottom lower left where my arrow is, and notice a couple of years later on the lower right with only an erbium laser decontamination. Here's an erbium YAG study done by Don Clem. This was, I believe, in the 2019 International Journal of Peri-Restorative Dentistry. Clinical study. Treatment using erbium YAG, but now adding osseous grafting, which is where I am moving towards, where I am. When we have walls after reflecting the flap and degranulating with the laser, decontaminating with the laser, and decorticating with a laser, then we come back and we're adding whatever you desire osseous augmentation wise. And here's a study by Ron Nevins, in which actually this is human histology study done with the erbium chromium using GM21 and bone and histology. And notice the before and afters. And if you look at the histology, again, you can see, and by the way, there was bone loss all the way down almost to the apex. And you'll notice how that this is not just bone in the vicinity, this is bone with re-osteointegration. And some clinical photos for you, before and afters, a couple of years, before and afters. Todd Jorgensen, periodontist in Arizona. Here, osseous augmentation. And literally mini flap using decortication with our laser. So let's begin to do a summation. What are we trying to do with both mucositis and implantitis? Well, removing the bacteria is easy, but the bacteria will come back, just like periodontitis. What we're trying to do is affect this implant surface for re-osteointegration, degranulate, removing those giant cells, memory cells, the neutrophils, plasma cells, lymphocytes, hyperactive, decorticating, possibly for bone morphogenic protein, and then adding augmentation. In mucositis, the only thing one can do is antimicrobial, unless you have an erbium. And yes, you will see me on non-surgical mucositis around an area that has gingivitis, no bone loss, but gingivitis around the implant, suppuration. I'll take an erbium laser and literally curettage the area. But in implantitis, I go to my 3Ds: degranulate, detoxify, and decorticate. So where are we with all of this? Personally, I believe it's erbium and CO2s around implants. I believe you have to be extremely careful with diodes and Nd:YAGs around implant surfaces. And I actually suggest that if you're going to use them in a sulcus, stay on the soft tissue side, but be very careful, if any, and don't touch the implant surface side. There are some articles a decade ago on how to remove an implant by deosteointegration with an electrosurge. And basically, you take the electrosurge and you touch the healing cap, and the thermal activity, you possibly can, with a reverse torque tool, unthread the implant, or wait a week, and you will be able to. If you take your diode laser or Nd:YAG laser and put it on those same kinds of settings, in other words, 1.5 watts, maybe up to 2 watts, initiated tip, continuous, not pulsed, you basically have an electrosurge. And therefore, you could use the diode to remove implants. But the problem with it is, if you don't want to remove the implant, be careful, especially also on second stage uncovery. There's a lot of folks that use diodes for second stage uncovery of implants. Just make sure you've got water there, and make sure that once you start to get close to the healing cap, do the rest with a curette or some type of degranulation device. And if you have bone over the top of that, then you're going to have to get out. If you have an erbium, you can remove the bone. If you don't, you can use a high-speed handpiece. So managing implantitis, remove the prosthesis is feasible. Closed flap, rarely, with exception of only about 10 or 15%. Everything else is an open flap, using laser, detoxifying the implant, bone augmentation, biologics, and possibly guided implant regeneration. In general, and this is what I'm saying to the dental profession, don't wait. The first time you see what you consider to be pathologic bone loss around an implant, apical to the machine surface, not submerged because you placed it too low, I mean, true pathologic, go ahead and reflect a mini flap and begin to degranulate, decorticate, and detoxify. Stop it. Don't let it get any further. Access to implant by both the hygienist and patient is an absolute necessity. And your prosthesis design should demonstrate that. What you can use on a tooth is not always what you can use on an implant. I hope I've been able to show you that relative to the different kinds of wavelengths. Present evidence for use of laser to manage implantitis is there with very good studies. And yes, there's a potential for new things occurring on the horizon. So I'm at the University of Florida. Again, this is my email address, my website. If there's anything I can do to help you as far as managing this to where it does not get out of control. It is starting to get out of control, by the way. There's a little bit of a backlash. You're seeing more and more endodontics done because of fear of loss of implants, because we're starting to take more chances than we did before. But just to suggest to you, when a patient loses a tooth from perio that you've been managing for years, they kind of appreciate that you've been able to keep it for this long of time. If you've ever taken an implant out on a patient, they're not happy. And now we're starting to do some psychological studies on patients, especially where we have to remove the implants, because there's not a real easy alternative, is it? But to place another one in there, not to even consider the expense that's associated with all of that. So therefore, I hope this has been helpful to you. And again, if anything that I can do to help you in your quest of keeping implants forever, do not hesitate to contact me. I also appreciate the Academy of Oral Surgery for inviting me again to share some thoughts with you.
Thank you so much for a wonderful presentation, Dr. Lau. Obviously, yeah, you know, I agree with you 100%. You know, I think this is we can call it like a pandemic for dentistry, because, you know, there's so many implants, and you know, we see it more every day that we're having some sort of bone loss, or, you know, and again, I'm not talking about complete failure. We're talking about, you know, again, in my book, a complete, you know, a failure doesn't have to be an implant that is coming out. It's an implant that's lost 2 or 3 millimeters. And exactly. What do you do with it? What do you do with it, right? I mean, if you know, I'm sure you've taken implants out, and it's not easy to take these implants out. Sometimes, you know, right? I mean,
it is, you know, as a, when we see these scenarios, I don't know which one's worse. A broken screw that I can't get out,
Right.
or an implant that needs to
Right.
come out. And how do I take it out? Do I trephine it out?
Yes.
You know, these holes that we make trying to take these implants out.
Absolutely.
I mean, you know, taking a root tip out, it's nothing compared to. And by the way, I didn't mention this, but we do take implants out with erbium lasers. You're aware of that.
Yes.
Because we take root tips out with an erbium laser because it can remove bone. So I will get in and take an implant out just as if I was taking a root tip out by making a moat with and then use a reverse torque tool and then hope that it will come out.
Absolutely. And using the laser is very conservative. So you're being very conservative.
Very conservative. You know, and we're in the area, we're moving towards where medicine is, aren't we? We're minimally invasive clinicians.
Absolutely.
The more we insult the body, the harder it is for it to repair itself. And it's a little bit of a sort of like a Middle Eastern spirituality thing for me, but I've always believed that if you remove the stimulus, the body will repair itself. So.
That's right. That's right. And Sam, you were talking about soon you guys are going to be starting doing some more hands-on laser training, and so that's exciting.
Yeah, we are looking forward to it. I'm actually, you know, you retreat to what you didn't think you needed to do until you are in a situation that forces you there. But there is some virtual hands-on training that we're also doing. And just to let you know that BioLays, for those who have been through the training, we now offer a evening 4-hour course virtually in which we send you a kit with a camera and models. And then someone like myself is on the other side on Zoom. And we literally for 4 hours go through managing periodontitis, implantitis, and to a certain degree, frenectomy, whatever, but those two primarily. And you're watching me work, I'm watching you work. And we never would have thought about that pre-COVID, but we have good cameras that we actually send to the participants and train them in an evening and 3 or 4 hours on it, back and forth, back and forth, back and forth.
That's amazing. That's amazing. Yeah, that's great, Sam. And I know you talked a lot about peri-implantitis and obviously their causes and you know, so we would appreciate, Sam, if you could later on take a look at the chat box if there's other questions that comes up, because you know we're sharing this video along with many thousands of viewers, and you know they might watch it now, they might watch it later. But we would appreciate if you could, you know, take a look and see and respond to those questions. I just want to go back, Sam, one more time again. We're really proud to have you as a part of, as a region of our Academy of Surgery. You know, you really, we appreciate every time you come. I know you're a busy man, and you know, you're basically everywhere, and we really appreciate you. I want to share again today. We have a powerhouse, 5 of our world-class speakers coming with us for the spring virtual. In fact, we have 2 more conferences coming. Hopefully, Sam, you're always a superstar. So we really appreciate having you every time. And you know, laser dentistry is, you know, it's one of those things that everybody wants to know about. Again, I really recommend all our colleagues to join us. We're doing this again, 1 more year of the first year free membership of Academy of Oral Surgery, and you guys can follow the link right here to register, and the Global Summit at the checkout. That's where you get that free. We've had over 500 new members just joined us in the past month. So we're very excited about this, and soon we will have a fellowship mastership we'll announce those as well. Also, we want International Extraction Academy hands-on workshop is scheduled. We used to do this a dozen times in a year around the country. Again, we're bringing them back with our obviously superstar Dr. Widerman and Dr. Morau this time around. So you kids can get 50% off of these courses by using the code AOS 2021. And with that, Sam, I would like to again thank you so much. We appreciate you very much. I wish you all the best and have a wonderful Sunday. And we'll see everybody soon in a few minutes. Thank you.
Thank you.